Thanks, Brooke. And hello, everyone. Thank you for joining. Excited to present the content in today's webinar. We have a lot to go over, so we will get started right away. This webinar explains 4 key changes CMS made to the Quality Payment Program. And these 4 changes come specifically from the 2021 Quality Payment Program Final Rule. And they create 8 new challenges for either ACOs in the Medicare Shared Savings Program, or ACO participants required to participate in the MIPS Incentive Payment System, or MIP, or the Merit-Based Incentive Payment System, or MIPS. CMS refers to MIPS eligible ACO participants as MIPS APM participants. And because CMS uses this blanket term to refer to ACO participants, you'll probably hear me use that interchangeable with ACO participants today. And I'll always be referring to ACO participants that are MIPS eligible. So trying to balance how these 4 changes affect everybody that comes together in an ACO, and consequently how that can domino effect into outside the shared savings program into the MIPS program. So with that, please notice that this webinar covers changes and challenges for these 2 distinct groups in the 2 programs. Keep this distinction in your mind as we go. Again, this webinar details first the 4 key changes from the 2021 final rule, the 8 challenges created by those changes, and then Health Catalyst's approach to these challenges. With that, we'll start with the 4 key changes. As you can see there, the 4 changes include the discontinuation of the CMS Web Interface, the introduction of the APM performance pathway, the distinction, or actually the discontinuation of the APM scoring standard, and the addition of the APM entity as a MIPS submitter type. This first section explains each of the changes, but does not yet discuss the challenges created by those changes. So let's get started with change number 1. CMS announced that it would discontinue the CMS Web Interface starting in the 2022 performance year. The web interface is a submission method CMS offers for quality measurement in the shared savings and MIPS programs. ACOs report quality data to Medicare using the CMS web interface. Additionally, over 100 groups report MIPS quality data to Medicare through the web interface. However, these ACOs and groups can no longer use the web interface to report quality data to Medicare starting in the 2022 performance year. So I know it's a little confusing that the 2021 final rule made that change for 2022, but I just want to make sure that those dates are clear in your mind. We're talking about the 2022 performance year. Next, change number 2. CMS introduced the APM performance pathway in the 2021 final rule. You've probably heard about this. The APM performance pathway, abbreviated as APP, is a new reporting framework for both ACOs and MIPS APM participants. By the way, CMS uses that term, or that phrase, reporting framework, to refer to unique scoring methodology or a unique set of measures or activities. So you'll hear me probably say reporting framework more than once today. I'll first explain the APP for ACOs, and then explain the APP for MIPS APM participants. ACOs that fulfill the APP fulfill their quality reporting requirements in the Shared Savings Program. In fact, the APP is now the required reporting framework for ACOs participating in the Shared Savings Program. CMS no longer measures ACO quality performance using the 23 former quality measures. Instead, the table on the screen lists the measures for the APP for ACOs. CAPS for MIPS is now one of the measures, and there are 2 administrative claims measures and 3 self-reported measures for ACOs that submit the APP using Ecqms and Cqms. However, there are 10 self-reported measures for ACOs that submit the APP using the web interface. The list of self-reported measures is the only difference between the 2 measure lists. And again, the list of self-reported measures differs based only on the submission method used by the ACO. However, remember that the CMS Web Interface is discontinued starting in the 2022 performance year, Consequently, all ACOs will report the APP using ECQMs or CQMs starting in the 2022 performance year. All right, that explains the APP for ACOs. Let's now talk about the APP for ACO participants, which again, CMS refers to as MIPS APM participants when they're still eligible for MIPS. MIPS APM participants that fulfill the APP fulfill their requirements in the MIPS program. Unlike the APP for ACOs, the APP is an optional reporting framework for MIPS APM participants. In other words, it is not mandatory for these participants. MIPS APM participants can submit the APP as a group or as individuals independent of their APM entity. And that's a change we'll talk about in just a minute. But by the way, CMS refers to entities that hold APM contracts as APM entities. So you'll also hear me talk about APM entities. For example, an ACO is an APM entity, and that's because the ACO is the entity that holds the contract. The table on the screen lists the measures and activities for the APP for MIPS APM participants. Again, notice that the list of quality measures in the APP is exactly the same for ACOs and MIPS APM participants. And again, the list of self-reported quality measures differs based on the submission method used by the participant. The table on the screen illustrates the list of measures for participants that submit the APP using ECQMs and CQMs. This table illustrates the list of measures for participants that submit the APP using the web interface. Like the APP for ACOs, MIPS APM participants submit the list of measures that corresponds to their chosen submission method. However, remember again that the web interface is discontinued starting in the 2022 performance year. While the list of quality measures is exactly the same for ACOs and MIPS APM participants, the APP defines requirements for all 4 MIPS categories for MIPS APM participants. CMS basically defers to APM requirements for both the improvement activities and cost categories, and participants would include the standard promoting interoperability measures in their submissions. All right, that covers change number 2, meaning the introduction of the APP. Let's move on now to change number 3. CMS discontinued the APM scoring standard in the 2021 final rule. The APM scoring standard only applied to the MIPS program. However, it applied to MIPS APM participants. The APM scoring standard required that CMS only use an APM entity submission to create an APM entity MIPS score, get this, for ACO participants. So I apologize of how many layers of concepts are built into that. But the basic idea is that ACO participants that are MIPS eligible only used to be able to receive a MIPS score through their ACO. And that's the arrow in this diagram pointing from MSSP for the Shared Savings Program over to MIPS. In other words, CMS used an ACO participant's APM entity score, even if the participant had other final MIPS scores. Even if a clinician's group or individual score was higher than a clinician's APM entity score, CMS still used the APM entity score to apply MIPS payment adjustments for that clinician. That's because the APM scoring standard dictated the former MIPS scoring hierarchy. The MIPS scoring hierarchy identifies the final score for a clinician that CMS would use to apply MIPS payment adjustments for a clinician. So there's final scores for these participants, and then there's final score, and that's the one that ultimately CMS uses to adjust payments. The MIPS scoring hierarchy is necessary because, as I just alluded to, clinicians can have multiple final MIPS scores. So notice, though, that the former scoring hierarchy prioritizes APM entity scores above other participation levels, meaning virtual group, and individual. Due to the discontinuation of the APM scoring standard, CMS revised the MIPS scoring hierarchy. Notice in the new scoring hierarchy that CMS no longer prioritizes APM entity scores above other final scores. Instead, CMS now uses the highest final MIPS score for a participant when applying MIPS payment adjustments, with one exception. For MIPS APM participants that can have up to 8 final MIPS scores, CMS will prioritize the use of a virtual group score if one exists. Otherwise, CMS will use the highest final score at any participation level in either the APP or traditional MIPS reporting, and those are two different reporting frameworks, which brings us actually naturally to change number 4. Change number 4 relates specific to ACOs. CMS added APM entities such as ACOs to the list of MIPS submitter types in the 2021 final rule. CMS defines submitter types as individual clinicians submitting for themselves or someone authorized to submit data on behalf of a clinician or practice. As a submitter type, ACOs can now submit traditional MIPS on behalf of MIPS eligible clinicians participating in the ACO. So notice in this diagram that the APM entity submits the APP to CMS for the Shared Savings Program. That's fairly a natural sequence here. So CMS uses that submission to create the APM entity MIPS score for all ACO participants. That's how they've always received an MIPS score through the ACO. And again, specifically, that is now the APP MIPS score at this particular level, which is the APM entity level. And that's why there's a line connecting the APP and the MSP or MSSP to MIPS in this diagram. A lot of acronyms, trying to keep going here, but you see that that's kind of how that scoring works. But note, however, and this is the uniqueness, that the APM entity can now submit a traditional MIPS submission. And that submission is colored orange in this diagram. So by the way, let me go back and also define one thing that I've been saying here. In contrast to the APP, CMS now uses the term traditional MIPS to refer to the original MIPS reporting framework, where participants select any measures and activities to report to CMS from the full inventory of MIPS quality measures and improvement activities. CMS will use the APM entity traditional MIPS submission to create a traditional MIPS score for MIPS APM participants at that APM entity level. So hopefully this table can clear up all the different participation levels and how those ACO participants that are eligible for MIPS can have these 8 scores because there's 4 participation levels in each of the reporting frameworks, those 2 reporting frameworks, APP and traditional MIPS. All right, that covers the 4 changes in the 2021 final rule that significantly impact ACOs and ACO participants. So next, we'll talk about the new challenges created by those changes, starting with challenge number 1. ACOs that previously used the CMS Web Interface to submit their quality performance must switch to a different submission method, also known as collection types, if that's a term that you've started using. Also, groups of MIPS participants that previously used the web interface to submit their MIPS quality performance must switch to a different submission method. The remaining submission methods applicable to these ACOs and groups include ECQMs through EHR reporting and CQMs and QCDR measures through qualified registries. Claim submission is grayed out because only small practices can submit quality measures to CMS using Part B claims data. ACOs and groups of MIPS participants reporting the APP must report the 3 self-reported APP measures using one of the alternative submission methods, meaning ECQM, CQM, or through a QCDR. ACOs and groups reporting traditional MIPS must report at least 6 MIPS quality measures using one of these same alternative submission methods. Different submission methods include different lists of quality measures. No submission method includes all 209 MIPS quality measures. This chart lists the measure counts for each submission method for the 2021 performance year. ACOs and groups should carefully evaluate the list of quality measures in each submission method to ensure they select a submission method that offers measures that match their strengths or specialty. And again, that's if these ACOs or groups are doing traditional MIPS reporting instead of the APP. So now that's the first challenge, is evaluating the differences between these two submission methods, and depending on which framework you're using, evaluating the different measure lists. However, the switch to a new submission method also includes the evaluation of 3 subsequent challenges, and those specific differences and challenges are what we'll talk about next. They're the next 3 challenges in our list here. So challenge number 2. ACOs and groups of MIPS participants may need to make care delivery changes when switching to an alternative submission method for 2 reasons. First, the web interface measured quality for only a sample of Medicare patients. However, alternative submission methods measure quality on all patients. That's not just all Medicare patients, that's all patients for all payers. Consequently, ACOs and groups that previously used the CMS Web Interface may need to make care delivery changes to fulfill quality measure requirements for all patients, not just Medicare patients. And second, ACOs and groups may need to make care delivery changes if reporting new measures for traditional MIPS. CMS noted that there are 10 ECQMs and 9 CQMs equivalent to the 10 web interface measures. For traditional MIPS reporting, ACOs and groups could report at least 6 of those measures if they prefer to not switch measures. Alternatively, ACOs and groups could report any 6 measures from the list of 209 total MIPS quality measures. However, ACOs and groups that switch to a new set of quality measures may need to make those care delivery changes to meet the requirements of the new measures. Challenge number 3. New submission methods may require ACOs and groups of MIPS participants to make data collection changes for 2 reasons. Here's reason number 1. As noted previously, alternative submission methods require quality measurement on all patients. In contrast, the web interface limited quality reporting to only a sample of Medicare patients. So consequently, ACOs and groups of MIPS participants could, if necessary, manually collect data from each of the 248 patient records for each measure. Then quality team members could review structured data, whether mapped or unmapped, or unstructured data, whether free text, documents, or images, to identify data or data collection that demonstrated fulfillment of each quality measure. Regrettably, this manual review is impossible or unmeaningful for quality measures that measure quality for all patients. And that would be because the denominator for the high blood pressure measure, for example, could increase from 248 patients to 2,480 or 24,800 patients for some ACOs and groups. Consequently, reviewing one patient record at a time is an impossible or unmeaningful task when measuring quality for all patients, not just a sampling of Medicare patients. ACOs and groups will now need to document or collect data in a way that can be extracted, aggregated, and submitted en masse. In other words, ACOs and groups will need to capture quality data as structured data that is mapped to standardized codes such as SNOMED, LOINC, RxNorm, CVX, or make sure that it's captured in regular claims data that can be calculated en masse. And many ACOs and groups will need to extract, aggregate, and submit data from multiple EHRs, and that's because alternative submission methods require ACOs and groups to report performance data for at least 70% of the patients who qualify for each measure, regardless of the distribution of those patients across different EHRs. Next, let's talk about how new value sets and alternative submission methods may require data collection changes. Medicare uses different versions of the same measure in the different submission methods. Technically, it's not the same measure, even though it's the same clinically. The difference between the measure versions is mostly the difference between the value sets in each version. The different value sets for different measure versions may dictate data collection changes. For example, ECQM value sets are more narrow than CQM value sets. Additionally, eCQM value sets are predetermined and cannot change. In contrast, CQM value sets are much more flexible, which helps you use all your data, not just some of it. ACOs and groups must evaluate the differences between eCQMs and CQMs to determine whether their existing data collection maps the different codes and the different value sets. But where discrepancies exist, quality teams must initiate data collection changes. Otherwise, clinicians will fulfill the measure's clinical intent, but still fail the measure. Challenge number 4, scoring changes. Performance rates vary for the same measure across different submission methods. Consequently, CMS creates different benchmarks for each submission method. The different benchmarks create uncertainty, however, when transitioning from one submission method to another. Specifically, the quality score for ACOs and groups could increase or decrease due to the transition from the web interface to alternative submission methods. That's because the same performance rate for the same measure can be worth more or fewer points in the different submission methods. So for example, notice on the screen that a 31% performance in the diabetes measure would earn different scores in the different submission methods. Specifically, a 31% performance earns earns about 7.9 points in the eCQM submission method. In contrast, a 31% performance would earn 10 points in the CQM submission method. And a 31% performance would have earned about 7.9 points in the web interface using MIPS scoring. As another example, notice that a 99% performance in the flu shot measure would earn different scores in the different submission methods. Specifically, a 99% performance earns about 9.9 points right up there by 10. So 9.9 points in the eCQM submission method versus 7.9 points in the CQM submission method. And a 99% performance would have earned 10 points in the web interface using MIPS scoring. So I present all of that just to show you that in these two examples, you can see how the same performance rate for the same measure can be worth more or fewer points in different submission methods. Consequently, ACOs and groups should be cognizant of these changes or these scoring changes. All right, that covers the 4 new challenges created by the discontinuation of the web interface. Next, we'll talk about the challenges created by the introduction of the APM performance pathway. But before we do, I'd like to learn from you through our first poll question. The first poll question asks, which of the challenges created by the discontinuation of the web interface is the greatest? My purpose is that you'd answer this question based on your specific role and responsibilities, rather than what might be true for everyone else involved. So again, what this question is asking is about the first 4 challenges that we just talked about related to the CMS web interface. And so at this time, we'll go ahead and launch that poll.
All right, so the poll question, Darren already read it for us, and your options are submission change, care delivery changes, data collection changes, or scoring changes. I'll give you a few seconds to get the votes in. Looks like we've got lots of votes coming in. Give you a couple more seconds. Couple more. All right, looks like votes are leveling off. We're going to close the poll and share the results. So Darren, looks like 44% of the majority said data collection changes, followed by scoring changes and submission changes, and then last is care delivery changes. Is that kind of what you expected to see?
The data collection change makes a lot of sense. And I wouldn't doubt that some of the 23% in submission change may have said basically all of it, especially data collection changes. So those answers certainly make sense. It'll also be interesting to review different responses based on different roles that people have had in participating today. So thank you everybody for your feedback, and hopefully that context helps you as well as you think about leveling up to some of these required changes. All right, now let's continue by discussing the next 4 challenges in our list. To do that, we need to now talk about challenges created by the introduction of the APM performance pathway. The introduction of the APP creates two key challenges. So these are additional challenges. First, CMS aligned the APP with the MIPS quality scoring methodology to create one scoring methodology for both the Shared Savings Program and MIPS. So that's good news. However, the bad news is that CMS estimated that the proposed methodological changes in ACO quality scoring will reduce the mean ACO quality score by roughly 10 to 15 percentage points. CMS did not specifically identify which scoring changes will cause the decrease in ACO quality scores, but like me, you probably can guess that that decrease would probably be due to reducing the quality measure count from 23 to 6, but with an emphasis on outcome measures. And then also that MIPS scoring methodology, which creates differences in scoring in the different benchmarks. Now, if this is news to you about this estimated decrease, you should know that the decrease in ACO quality performance won't affect the final shared savings rate for ACOs in the Shared Savings Program. And that's because starting in the 2021 performance year, CMS will award the full shared savings rate to ACOs that meet or exceed the quality performance standard. But ACOs should be aware of the potential for CMS reintroducing a final shared savings rate in the future that is contingent on quality performance. That's challenge number 5. Challenge number 5 creates challenge number 6. So the decrease to ACO quality scores creates challenges specifically for ACO participants that are still eligible for MIPS. In previous years, MIPS APM participants or ACO participants benefited from high ACO scores, MIPS scores that came from their ACO. However, the decrease in ACO quality performance will decrease the APM entity MIPS scores credited to ACO participants. So you can see the example on the screen here. MIPS APM participants with a 93 for their APM entity score last year should expect something like a 90 for their MIPS APM entity score this year. That's how the decrease to ACO quality scores simultaneously creates a new challenge for ACO participants. And that 3 points is expected to be worth potentially, I had to pick a couple number here, but that 3 points would be worth $170,000 in MIPS payment adjustments for a group with $20 million in Part B payments. So that 3 points is significant, even in this era of MIPS payment adjustments ramping up and still being less than what they could be. It's still significant. So be aware of that domino effect. Challenge number 7. Challenge number 7 comes from change number 3. Due to the discontinuation of the APM scoring standard, clinicians classified as MIPS APM participants could have up to 8 final MIPS scores when a participant has multiple MIPS submissions. As you can see, those 8 final scores are created by 4 participation levels in 2 reporting frameworks, meaning the APP and traditional MIPS. MIPS APM participants must now determine which MIPS reporting framework and which level of MIPS participation would put forward their best MIPS score. That will require these participants to monitor and improve their scores using the different frameworks at the different participation levels. This same complexity also is also something that a value-based care leader must manage for a health system that runs an ACO and employs providers in that ACO who are MIPS eligible and therefore have MIPS payment adjustments. Challenge number 8, our last and final challenge to discuss in this list of challenges created by these changes. Challenge 8 comes from change number 4, meaning the addition of the APM entity as a MIPS submitter type. So as I noted previously, ACOs can, but do not have to, submit traditional MIPS quality measures. Consequently, ACOs must determine whether they will submit traditional MIPS quality measures on behalf of their ACO participants. Alternatively, ACO participants could put pressure on ACOs to submit traditional MIPS quality measures for their benefit. For example, if They knew that their MIP score that they received from their ACO participation could be higher with those measures. Additionally, in another set of circumstances, health systems that manage an ACO and employed participants in the ACO must determine whether submitting traditional MIPS quality measures could increase the APM entity MIP score and therefore increase the MIPS payment adjustments for the system's employed providers. So that's challenge number 8. That's the introduction of new complexity due to the addition of the APM entity as a MIPS submitter type. All right. So those are our 8 challenges. So that concludes the second section of today's webinar. And so with that, what I want to do is summarize those 8 challenges mapped to the changes. I've included this summary slide because I now want to ask you a second poll question related to this outline. The poll question asks, which of the changes creates the greatest challenge or challenges? Consequently, before we launch the poll, I wanted you to be able to clearly outline the changes and challenges in your mind. So take 5 more seconds to summarize this in your mind, and then we'll launch that second poll question. So once again, here's the outline. And then here again is the poll question. Which of the changes creates the greatest challenges? Like in our first poll question, please answer this question based on your specific role and your responsibilities. We'll go ahead and launch the poll now.
Okay, so your options for this poll question are the discontinuation of the CMS Web Interface, introduction of the APM performance pathway, discontinuation of the APM scoring standard, addition of APM entities as a MIPS submitter type. Give you a few seconds to vote. Got some votes coming in. Thanks again for participating in our polls. Couple more seconds. And looks like votes are leveling off. And I will go ahead and close that and share the results. So we've got kind of a little bit of a split here. We've got 39%, looks like discontinuation CMS Web Interface, and then a couple other options kind of all spread out. What do you think of that split, Darren?
Well, one thing that was fascinating to watch was that people who believe that the discontinuation of the CMS Web Interface creates the greatest challenges, they're emphatic about that, and there was no thinking about it. Because as we watched the results come in, that answer shot well and far into the lead. And it seemed like if that wasn't your answer, then there was more deliberation between the other 3. So I would expect that the discontinuation of the CMS Web Interface would create the most challenges for everyone, like all together. But of course, different roles and responsibilities, mean that different changes create, or the challenges are much greater for someone who bears the full responsibility of those challenges. So this distribution makes sense to me. I hope it makes sense to you all as well. So thank you for your participation. I hope these poll questions help you kind of get a sense too about what everyone else is thinking. And again, it'll be interesting to review your responses later to determine how different roles and responsibilities dictate different answers to this question. Now, let's continue on to the third section of today's webinar. We've now covered the 4 changes and the 8 new challenges created by the 4 changes. The final section in today's webinar illustrates Health Catalyst solutions for these changes and challenges. Now, if our solutions can help you overcome the challenges that we just talked about, we'd certainly like to meet with you and talk with you more in depth about each change, each challenge, and each solution. However, our purpose in presenting our solutions to everyone on this call is so that you can start to envision solutions to the 8 challenges by seeing how we've approached each of the challenges. So for the first 4 challenges and our solutions for those challenges, allow me to turn the presentation over to Rachel Cates, who will present Health Catalyst solutions to the first 4 challenges.
Thank you, Darren, and thanks to everyone for joining us today. As you can tell, Darren is truly the resident expert on this program and these changes. And if you're anything like me, it can get to be kind of a acronym soup. So if you do have follow-up questions, nothing is too simple. This is brand new and there are a lot of changes, so definitely encourage you to put it in the chat box. I'm going to talk a bit about the solutions that We have created to address some of the challenges that Darren just mentioned. But before I do, let me just give you a broad view of what our quality measure solution looks like at Health Catalyst. So Health Catalyst quality measure solution creates a complete picture of your quality performance by combining your data from multiple sources, as you see in this diagram, and providing you measures across multiple quality programs, and then visualizing your performance in these programs. Then we integrate your quality workflow by combining the process for monitoring and improving quality with the process for submitting performance for different programs and different payers, including Medicare. So we know that sometimes quality improvement and quality compliance and submission can feel like two sides of or just very separate projects, and we aim to bring those together with our quality solution. So now let's talk about how the different components of our solution overcome those challenges that Darren just detailed related to the 2021 final rule. So let's talk first about how Health Catalyst quality measure solution overcomes the challenges created by the discontinuation of the web interface, which was the #1 concern among our participants today. Regarding the need to switch submission methods, Health Catalyst provides a qualified registry, which is called the Able Health Qualified Registry. And through that registry, we offer CQM submission through our online submission engine, which connects to CMS via our API, our application programming interface. So quality teams can measure and submit your performance directly to CMS from within Health Catalyst performance dashboard. So to summarize, we offer a qualified registry to replace your CMS Web Interface submission. Specifically, ACOs and MIPS APM participants can submit your performance to CMS for the 3 self-reported measures that Darren talked about in the APP. Alternatively, ACOs or groups can report any CQM available in traditional MIPS. So that's the other option with those 200+ measures through our submission engine directly to CMS. So it's really a change of paradigm between the sampling methodology that was involved in CMS Web Interface submitting to a full population-based submission directly to CMS from your data warehouse. All right, let's talk about challenge #2 and what we've done on that front. So challenge #2 relates to care delivery changes that are mandated or required in some cases by the fact that you're now looking at your full population instead of just Medicare patients and even just a sample of Medicare patients. Health Catalyst quality measure solution addresses this by enabling ACOs and MIPS participants to rapidly expand care delivery for quality measures across all patients, not just the sample of Medicare patients. And we do that by providing performance dashboard visualizations like the one you're seeing here that view performance across the full population and empower quality leaders and providers to monitor and improve performance across all measures and critically all patients, which is the big change with the new rule. And something that we've found in our conversations to date is making a lot of people nervous. You know, how do you go from a time when you're really focused on your Medicare population and you're focused on a sample at the end of the year to a time when you're really focused on your whole population? And our view is that you need software in place to monitor performance throughout the year on your whole population, which we know a lot of folks are working toward and is also very difficult for a number of reasons, one of which is, as Darren mentioned, the use of many different EHRs across a network. Additionally, Health Catalyst solutions can embed care gap lists into native EHR workflows for use by the care team at the point of care. And this is designed for use across patients. You know, at some point, it becomes untenable to use non-automated either paper-based or spreadsheet-based or report-based solutions for care gap closure. And when you're expanding your efforts to your full patient population, which many folks do, for example, for HEDIS measures or so on, but in this case, you know, it's becoming more and more important for health systems to embed these insights into the workflow so that they are actually getting to the providers at the point of care. So these two components, the visualizations and the workflow, workflow integration, empower ACOs and MIPS participants to facilitate those care delivery changes that are necessitated by these new submission requirements and the fact that you're now dealing with your full patient population. All right, challenge number 3, data collection changes. So Health Catalyst's quality measure solution includes the Health Catalyst data operating system called DOS, which is a system that integrates all source data, so claims, clinical, payer data, all relevant source data into a single computing ecosystem, and it combines features of data warehousing, clinical data repositories, and health information exchanges. With DOS, you can combine complete data types and data sources into one place and then map all your structured data to the appropriate code types for the value sets used by the measures in your new submission method. So many folks noted that value set changes were going to be difficult for them. You know, this is how we are approaching it at Health Catalyst. It allows you to collect and aggregate data from all your source systems in a way that can be extracted, aggregated, and submitted in mass, which is really necessary for the data collection changes that are required. For some folks, this is an incremental change where, you know, there's already a big effort going on and just some additional sources need to be brought in. For some folks, this is kind of a massive paradigm shift in terms of having a centralized data repository that you're doing the measure calculations off of. That includes multiple, in many cases, multiple EHR sources as well. Okay, and challenge number 4 is scoring changes. So you recall that there are different benchmarks for different types of measures, even the same measure in different submission methods, sorry, to be more specific. And the CQM benchmarks and measure scoring in our solution are embedded into the performance visualization. And because of this, you can continuously monitor and manage your measures in relation to the benchmarks for each measure. And this is just important in always knowing where you stand on the program and if there are any areas where you need improvement, where previously it might not have been something you track all year, or that you can so quickly see, you know, where do we stand relative to the benchmarks. As the complexity increases, as the stakes increase, and as the patient population increases, having this at your fingertips, we believe is increasingly important. Additionally, the data operating system and the Health Catalyst flexible measures engine can use all your structured data in performance calculations, not just some of it. So this is a really critical difference between that eCQM option and the CQM option. So eCQMs have a much more prescribed set of data elements that are available to use. The CQM option is what we do, which allows you to be more flexible with mapping any structured data into the measure and counting it, so that we can make sure to accurately capture the care that's actually being delivered. And, you know, in many cases, we've seen that this flexibility can make the CQM submission method more appealing. I do want to note that in many cases, the benchmarks for CQMs are higher than for the eCQM equivalent given any given measure. But many organizations find that the data flexibility in the CQM measures more than makes up for that difference in benchmarks. And it really is a decision, organization by organization decision on which makes most sense. And the more data you can have about what your performance rates are and what the benchmarks are and where you stand, the better positioned you'll be to make that decision. Okay, so that's how Health Catalyst Quality Measure Solution overcomes the first 4 challenges created by the discontinuation of the CMS Web Interface. So please, again, put any questions you have so far into the chat, and we'll be online shortly to answer those. But for now, I will hand it back to Darren to talk about how the solution overcomes the challenges created by the introduction of the APP.
Awesome. All right, let's finish out these last 4 challenges. As noted previously, CMS estimates that the new APM performance pathway and scoring will decrease ACO quality performance. And again, that decreases APM entity MIPS scores for ACO participants. So CMS, again, didn't identify all those specific factors, but we know one key difference would be the use of MIPS quality scoring and those different benchmarks. And as discussed in the previous section, the Health Catalyst Quality Measure solution can offset bottlenecks in data collection that reduce quality performance for various measures and different submission methods. That's because, again, that the DOS system and the flexible measures engine. Consequently, DOS benefits both ACOs and ACO participants facing this new challenge, meaning CMS's estimated decrease to ACO quality scores. Additional factors that could explain a decrease in performance include the reduced list of measures, which includes process measures with historically high performance for most ACOs. Health Catalyst Quality Measure Solution allows ACOs and ACO participants to improve quality performance with specific improvement tools, which Rachel already highlighted. So again, those tools include intuitive dashboards, and then also the embedded care gap lists. And specific to ACO participants, the Health Catalyst Quality Measure Solution allows these ACO participants to monitor, improve, and submit their MIPS performance independent of their APM entity, meaning at the group and individual levels. So notice in the orange box on the screen that these users can toggle back and forth between performance at the group and individual level. Additionally, notice that users can submit performance at the group and individual levels. Consequently, MIPS APM participants should seek to improve and submit their MIPS performance independent of their APM entity, or at least control their destiny where it makes sense, meaning where that performance is truly higher than the APM entity score due to this estimated decrease. So now, the solutions that I just described for challenge 6 also support challenge number 7. So as noted previously, clinicians classified as MIPS APM participants could have up to 8 final MIPS scores. And due to the discontinuation of the APM scoring standard, CMS will now apply payment adjustments using the highest final score for MIPS APM participants. So consequently, quality teams can use Health Catalyst Quality Measure Solution to monitor, improve, and submit performance for MIPS APM participants at all the different levels of participation for both the APP and traditional MIPS, including the APM entity level. Those submissions can include MIPS quality measures, promoting interoperability measures, and improvement activities, meaning all reportable MIPS categories. And so why that matters is because half the groups in an APM entity will have a group score higher than the APM entity score. Consequently, quality teams should report these groups independent of the APM entity. Additionally, half of individual clinicians in a group will have an individual score higher than the group score. Consequently, quality teams should report these individuals independent of their group. And of course, there's all kinds of statistics that go in this, so I'm just speaking loosely here, but that's why this matters. And so CMS will receive and assign multiple final MIPS scores for these ACO participants, including the APM entity scores, group scores, and individual scores, and any virtual group scores as well. And due to the discontinuation of the APM scoring standard, again, CMS will use the highest final score. And so that's why that change creates good and bad complexity. Now, our last but certainly not least significant challenge, as noted previously, APM entities can, but do not have to submit traditional MIPS quality measures now that CMS includes APM entities as a submitter type for MIPS. But APM entities such as ACOs can use the Health Catalyst Quality Measure Solution to monitor APM entity performance in the APP and traditional MIPS. Health systems that manage an ACO and employ participants in the ACO can submit the APP for Shared Savings Program participation and traditional MIPS quality measures. That submission can also include improvement activities for traditional MIPS. And for a health system with both an ACO and employed providers in the ACO, this capability ensures that the highest MIPS score will be submitted at the APM entity level and increase MIPS payment adjustments for those employed providers that are MIPS eligible. All right, that covers how Health Catalyst approaches these 8 challenges created by 4 changes that affect ACOs and MIPS APM participants. And again, if our solutions can help you overcome the challenges we just talked about, then we would certainly like to meet you, talk with you in more depth about each change, each challenge, and each solution. However, again, the purpose in presenting our solutions to everyone on this call is so that you can hopefully get a spark of creativity from how we've approached each challenge specifically with our solution. And yes, we're also proud of what we've put together and brought out as solutions as well. So at this point, what I want to go ahead and do is, for sake of time, I'm going to skip our last poll question, or not our last poll question, our third poll question, and go straight to our last poll question right before we kick off into our Q&A session. So for that, I'm going to go ahead and turn it back over to Brooke. But Brooke, actually, before I do, I wanted to just note that I referenced that the content from today's webinar will be or already is on our website. So if you tried to take notes but couldn't keep up because, again, all of the different acronyms or abbreviations, that is, just know that the exact same content, almost with the word-for-word explanations, are in our Knowledge Center underneath of the latest insights. And I might even be wearing the same exact outfit in this picture. So you can find all that information there on our website. So with that, Brooke, I'll turn it back over to you.
Thanks, Darren, and thanks, Rachel. If you have any questions, now's a great time to submit them in the questions pane on the GoToWebinar control panel, and we will begin our Q&A session in just a moment. We do have one final poll question for you. I'll go ahead and launch that. So while today's webinar was focused on the new challenges and changes with the 2021 QPP final rule, some of you may want to learn more about Health Catalyst products and services. And if you'd like to learn more, please answer yes to this poll question. And I'll go ahead and leave that open for a few minutes as we jump into the Q&A. So Darren and Rachel, we've got a lot of great questions that have come in, so we'll try and get through as many of them as we can. Our first one comes from Carol, and she says, can we continue to report WI samples of patients as a MIPS APM in 2021?
I'll take that. Yes, the web interface is still available in 2021. Originally, CMS had proposed that the discontinuation would be effective for 2021, starting in 2021, meaning that you would not be able to use it. But after a lot of comments came in on the proposed rule, CMS extended that discontinuation and said that it would be available for the 2021 performance year, but not available for the 2022 performance year.
Perfect. Okay, and then another question from Carol. She says, would you define again the difference between the traditional MIPS measures and the APP measures, and why the quality scores may be better with traditional measures?
I think the traditional MIPS measures could be, one of the examples, by the way, that CMS gave as an answer to this exact question was just due to kind of the specialty or specialist makeup of an ACO. And if, for example, reporting measures that match the measures in the APP would benefit, those could all be included, but then in addition to that, a very high performing specialty specific measure. And so it's all about all those different circumstances that could come together to make a traditional MIPS submission better.
And just to answer the first part of the question, the difference between the APP measures and the MIPS measures, the MIPS measures include the full set of 200 plus available MIPS measures that you know of from MIPS in the past. And the APP measures are a pre-prescribed set of measures that include only 3 designated self-reported measures. So you don't have any choice with the APP measures. And so that's why Darren was saying in the case of choosing MIPS measures, you have much more of a choice, but you have to do more measures. And in the case of an APP, you have fewer measures and no choice. So depending on a specialty, for example, you may want that flexibility that the MIPS measures offer.
Great, thank you. Okay, next question is from Melissa. When you say all patients and all payers, does that mean only the TINs under the ACO/MSSP contract, or all patients of the ACO outside of the MSSP?
Rachel, help me out on this one, but it should just be anything that has been billed, correct, through the ACO.
I don't know the answer, so I think we should get back to this participant after the
That sounds good. Yeah, forgive me. We'll get back on that one. Thanks so
We'll
much.
get back to Melissa on that question. Okay, next question. Denise asks, is it true if a practice submits data through their vendor for MIPS that CMS will attribute the scores to the APM if they are in an APM?
If, like, for example, if the vendor in this example is Health Catalyst, well then yes, absolutely. I think that's how I heard the question asked, meaning you're going to use a third-party intermediary, which is what the Able Health Qualified Registry would be. You would be submitting through that vendor, which and then that score would go to CMS, and that's all credited to you. Rachel, is that how you understood the question?
I think the question is, if they submit through, for example, our registry for MIPS, will CMS then attribute the scores to the APM if they're in an APM?
No, my understanding is no, but I can double check that. And I'm 99% certain on that. It's only a one-way street between the Shared Savings Program over to MIPS.
But not MIPS to the APM is what you're saying?
Correct, yeah.
Okay. Confirm that.
Okay, great. Next question is from Trina. Can you explain the difference between eCQM and CQM?
Yeah, I spoke about that topic a bit, so I can take that. So the eCQMs are what you may know as EHR measures. So they're certified measures that are often included as part of certified EHR technology, ONC certified, that may be familiar to you. So, A1C or blood pressure, these can be all eCQMs built into your EHR and certified. CQMs are just clinical quality measures without the electronic at the front. And there's a much broader scope of these measures, and they must be performed by a qualified registry. The calculations must be performed by a qualified registry, but they don't have to be certified by ONC. And they're far less prescriptive in terms of which data they use. So for example, in your eCQM version of the A1C measure, you may have to pull from a certain field in the EHR only. From the CQM version, if you've documented that information elsewhere, it could be mapped into that measure. So it's less prescriptive. And then there's also just far more of them. So I think there's 60 or 70 eCQMs that exist, and 200 plus CQMs that exist. And in particular, in the context of the APP, there are 3 relevant measures, and they all have both eCQM and CQM versions. So that's kind of the main thing we're talking about here. And just to review, in that APP program, the eCQMs and the CQM versions have different benchmarks and different kind of data collection requirements. So those would be the differences to evaluate as you think about which version you want to use. Darren, anything to add?
No, that's perfect.
Great. Okay, next question. Nadia asks, when reporting APP, how does CMS know that we are reporting under APP rather than traditional MIPS?
Yeah, we actually are asking this question as well from our perspective as a qualified registry. And before I answer that question, Rachel, have you heard what we may have heard in a okay, we're asking that same question as well. I mean, ultimately, we're submitting straight to CMS, and because there's a one-way street, CMS would be able to naturally triage everything that needs to be triaged. So when CMS receives that APP score from an ACO, that creates that highest level participation option over on the MIPS side at the same time. So there's the MSSP score that needs to be created, and then simultaneously it's that highest level APM entity score in MIPS. And so CMS can naturally triage that because, again, like we alluded to a second ago, if submitting either at the group level and you're submitting the APP, CMS isn't going to bubble that up for ACO performance. And if a traditional MIP score comes in, it can't go over to the MSSP in that what I call the one-way street.
Yeah, just from a kind of nuts and bolts perspective, I'm in the same boat as Darren. We're not sure yet the details, but my guess is based on how MIPS reporting works through a registry, which is what we know most about. My guess is there'll be some kind of flag that or box you check, or something that we then send over to indicate some kind of indication that you'll elect to choose, is my guess, but we will be learning more over the coming weeks and months.
Okay, and then these are our last question. Well, we've got a couple more. We'll see if we can get through. I know we're at the top of the hour. We'll try and get it through a couple more. Shyla asked, is Health Catalyst a qualified registry for CQM?
Yes.
Okay, perfect. Looks like she has a couple other questions. How do you determine if my company should make the switch to reporting with an ACO, and how do I find that in my area?
Like, for example, sometimes it's hard to envision in your tools how that would be done, so I'll talk specific in our tools. In our tools, you would just measure your performance in those different reporting frameworks, so the APP and traditional MIPS, and then at the different levels of participation, so group and individual. And again, loosely speaking, statistics-wise, half your individuals are going to have a higher performance than your group, and there's the potential that your group has a higher performance than your ACO. However, you would need to know if the ACO is modeling out what the MIPS score would be. And so that's a bit tricky. So they may or may not be doing it, but that would be how you'd handle it in your specific setting. If this was all contained within the same organization, that distinction would be in our performance dashboard. But I just don't know what tooling is available at the ACO to know that. But so know your score and then ask the ACO if they're modeling that score at that highest level.
Perfect. Okay, this I think will be our last question, and we'll wrap up. It says, this is also from Shyla. The company I'm working for uses our EHR to submit. Our service contract for our MIPS submission assistance ends after the 2020 submission. Health Catalyst could potentially be something we look as an alternative way to submit for 2021. Do you only provide services for companies that submit as ACOs?
No, we provide services. We can submit both for an ACO only, or, well, actually 3 scenarios: for an ACO only, or for an independent medical group needing to report for MIPS, or for a health system that has both, that runs the ACO and needs to do MIPS submissions as well.